opportunity. I would like you to spend just one extra second on this slide because these are heated debates and I'm sure I want to say that I'm not with any company.
Yeah. Question is to bring the best.
Yeah, but this is an important slide. Okay, the rest is all debate. So I would first say points against my other two opponents. So what is the problem with combining PDT and Lucentis? We are doing here full fluence PDT. We know that it causes choroidal ischemia. We know it causes photoreceptor degeneration in the long term. You know, it started with the laptop study which compared Lucentis to PDT in 2013, and they have shown loss of visual acuity with PDT. Then we come to the Everest study, which is the cause of all this hue and cry that you combine the two treatments. We just have 1-year results right now. And in that also 40% of the cases have required more than one PDT session and they are not off Lucentis. Yes, the number is little less, but still it is there. And we know that PCV is a variant of type 1 CNVM. And let's go back to history. The initial TAP and VIP studies, they told us that PDT works better for a type 2 rather than a type 1. Again, all of us know that cost of PDT is there. So does it justify? Can you overrule the potential risks of photoreceptor damage? Are we just pushing PDT again? So that is for PDT with Lucentis. Why not just Lucentis? Now for the other opponent who wants to say that Eylea is the best one. Well, again, this started with a study in which they took patients who already had good visual acuity. If you have good visual acuity, you will have better gains. Then comes the Planet study, which says that there is no difference in combination of PDT with Eylea and monotherapy. So again, here they are kicking the PDT part. But if you don't even look at the PDT, if you see the in between the lines, they find that complete polyp regression with Eylea also is as much as it is with Lucentis. So the prohibitive cost is always there. They also say that there is more flattening of PDT. Now if we see a post hoc analysis of Lucentis study, they tell you that a higher flattening of PDs also causes a higher rate of macular atrophy. So do you actually need to flatten them out totally? You can get into atrophy and then later problems. So let us stick to Lucentis. Everest 2 study, monotherapy and combination group. Combination they said is better, but there is only a 3-letter difference, not even a single line on ETDRS. How much does it actually matter for the patient? And see the ICGs carefully. The branching vascular networks do not go. This is one of my patients. I injected Lucentis and gas. The blood has gone down. The old hemorrhage is there. Patient improves to 6.6 because the fovea is not involved. You do an ICG, you get the polyps and the branching vascular network. I thought, let me add PDT. I did PDT, patient is still doing better. But again, he bleeds after 2 months. You do an ICG again, and you find that there are new polyps which have developed. Now these are extrafoveal, so I do focal laser for this. But what about the BVN? Despite PDT, the BVN doesn't go. See, it's still there as large as before. So the patient is good, but PVN still persists. There is a risk of bleed again in this patient, and I know that this patient in the future will bleed and will require still again an anti-VEGF injection. So let us stick with Lucentis. It is time tested, it is cheaper, PRN dosing works, it has a better safety profile. So till we have better long-term data, I say let us just stick to Lucentis. Thank you.
Shobit is here.